Welcome everyone to the Bale Doneen Guest Webinar series. My name is Julie Morin. I'm the Chief Business Development Officer for the Bale Doneen Method. Tonight we are very excited to welcome Dr. Tom Larkin as our speaker. Before I formally introduce Tom, I would like to give you some background on the Bale Doneen Method. I know some of you are not familiar with the program. So Dr. Bradley Bale and Dr. Amy Doneen co-founded the Bale Doneen Method, which they teach to healthcare providers in their American Academy of Family Physicians accredited preceptorship program for the prevention of heart attack, stroke, and diabetes, and in their online CME courses. They've given hundreds of lectures at leading medical conferences globally and have published their scientific research in many peer-reviewed journals. Dr. Doneen is Medical Director of the Heart Attack and Stroke Prevention Center in Spokane, Washington. Dr. Bale serves as Medical Director of the Heart Health Program for Grace Clinic in Lubbock, Texas, and has a private clinical practice in Nashville, Tennessee. Their critically acclaimed book, Beat the Heart Attack Gene, is available on Amazon. Tonight, Dr. Tom Larkin is joining us. Tom is a dentist, author, professor, lecturer, entrepreneur, and graduate of the Bale Doneen Method. He has written 2 books on dental practice management and 2 books on oral wellness. With an extensive background in clinical preventative dentistry, he brings a unique perspective to the emerging field of oral systemic practice. In this 1-hour webinar, Dr. Larkin will be discussing dental diagnostics in support of the Bale Doneen Method. There is a tremendous amount of interest and enthusiasm around what has been coined the oral systemic dental practice. The actual implementation has proven to be a considerable undertaking. In this presentation, Dr. Tom Larkin will describe a step-by-step diagnostic protocol that is necessary to support a Bale Doneen Method practitioner and how to overcome specific barriers to case acceptance. Tom is currently the Clinical Director of Ideal Practices, a company that encourages and supports the independent practice of dentistry by developing startup practices. So Tom will be giving his presentation, and at the end we will open it up for questions so that he will be able to answer and help you understand what he's doing. So welcome, Tom, and I'm going to turn things over to you.
Thank you so much for that kind introduction. So my talk tonight, I'm going to take you on an interesting journey. I'm looking at the title, Dental Diagnostics in Support of the Bale Doneen Method, and that seems a little dry on the surface. So kind of follow along with me. This is a quotation that I learned about 20 or 25 years ago. And this quotation says that people don't value what they don't understand, and people don't buy what they don't value. And I have found that quotation to be a solution to many of the dilemmas that we have in business and in life. And one of my goals is to see the full integration and the full implementation of the Bale Doneen Method. So I'm always looking for ways that I can help. And I see an emerging problem here in semantics. And the problem is lack of definition. In the past 5 years, I've seen the words complete health dentistry, total health dentistry, oral systemic, oral wellness. And I'm in circulation with hundreds of young dentists. And if I was to ask 50 people what any of these meant, I would get 50 different answers. So I think it's important that we work towards defining, because I know that this misunderstanding is leading to inaction. And my whole goal is to motivate people to move forward with these concepts. So my presentation tonight is in 3 sections. The first is a brief history. When I'm presenting to young doctors, I always have a history lesson. I think it's important. The second part is my backstory. And then I'm going to talk about dental diagnostics and also clinical protocol in support of the Bale Doneen Method. So in 2004, this was kind of a landmark moment for consumers. This was a new concept being presented that said, inflammation caused a host of systemic problems. But for the dentists in the audience, I'm going to go back a lot further. I'm going to go back to 1880 when Dr. Willoughby Miller was in the first graduating class in Penn. And about a decade later, he had an interest in microbiology, and he found himself in Berlin, Germany, in the lab of Dr. Koch, the famous Koch's postulate doctor. And one of the contributions of Dr. Miller was the focal infection theory, that the mouth is a focus of infection where microorganisms can gain entrance to parts of the body adjacent to or remote from the mouth. The focal infection theory is central to the Bale Doneen dental evaluation, and this theory has historically largely been ignored by dentists. So Dr. Charles Mayo and his brother, who founded the Mayo Clinic, these people were very, very strong advocates of dentistry. And around 1915, Dr. Charles Mayo made the comments that he felt as if the mouth was by far the greatest portal of entrance of germ life into the body. He also stated that complete dental care and preventive measures can extend human life 10 years. And then he challenged the dentists of the generation and said the next great step in medical progress in the line of preventive medicine should be made by the dentist. The question is, will they do it? The answer was a resounding no. Dr. Thomas Hartzell was a very interesting individual about the same time, and he described neglected teeth as gateways for deadly germs into the body. And I found a newspaper article, and he was presenting at the National Dental Association, which was the precursor to the American Dental Association. And he talked about Bright's disease. I had to look that up. That was nephritis, heart failure, rheumatism, and insanity caused by germs underneath fillings. And so what I've done here is I've taken a little bit of a liberty. I hope that Brad and Amy don't mind. I think most of us are familiar with this diagram. And I went ahead and added insanity to that inflammatory tree. And I want you to ponder this. With periodontal disease today at a rate of 70 to 80% nationwide, and Hartzell linking inflammation with insanity, I think I may have solved the mystery of what happens when we turn on the nightly news. So Thomas Hartzell also had a really very fundamental, famous quotation, and he said that the multitude of bacteria that grow in the mouth has confused dentists to such a degree that they refuse to accept the fact that the destruction of teeth and tissues is a bacterial matter, and they subsequently discredit all bacteria. Now, I want you to know that for 60 to 70 years, this exact argument has been used to discredit people that brought forward the concept of bacterial infection. It wasn't until the advent of oral DNA that this became more widely accepted. Weston Price was an incredible individual. I know there's going to be people here listening tonight that are interested in nutrition. If you have any interest at all in nutrition, you need to get this book. It is an absolute fascinating read. And the title is Nutrition and Physical Degeneration by Weston Price. Dr. Price also authored Dental Infections, Oral and Systemic, Dental Infections and Degenerative Diseases, Fundamentals of Oral Expressions of Dental Infections. Why have you never heard of Weston Price? You never heard of Weston Price because of this. This is a fact sheet from the American Academy of Endodontics. In the 1920s, in addition to nutrition and all these incredible things that Weston Price did, he came up with a theory that root canals could potentially cause systemic disease. And this was not very well accepted. And the last line here said, this was before medicine understood the causes of such disease. This is an article that I sent to Brad and Amy a couple of months ago. This is a research study, and there are many, many, many research articles. But this was one done in Europe that said that dental root tip infections increase the risk for heart disease. Rest in peace, Weston Price. We're going to get it sooner or later. In 1989, I had the good fortune of traveling to Washington, D.C. and making a dramatic change in my life and in the life of my practice. My practice became under the mentorship of Dr. Paul Keyes. His contributions to modern-day prevention stand alone. With nearly 30 years at NIH, he defined the etiology of both gum disease and decay, the transmissibility of gum disease and decay, and he recommended aggressive anti-infective treatment. So I went back to my practice in 1989, and I went from disease and treatment to health and prevention. And this was my brochure in 1989, Modulated Microbiological Periodontal Therapy. This is the inside of the brochure, and I want you to look at this column that says disease-related microorganisms. Remember that comment about Thomas Hartzell in 1927. So what Keyes did is he narrowed the group. He could not specifically point to which ones, but he narrowed the group. This was not enough for organized dentistry. Now, in the Keyes technique, the emphasis was only on bacteria. We talked about bacteria and infection. We never talked about pockets and things like this. So this is an updated version of that same brochure. And what I want patients to understand today is that as a biofilm becomes more mature and more pathogenic, it changes in character. And that's what this left-hand column shows. More microorganisms shows up, more white blood cells in response to infection shows up. And I want patients to understand that where these bacteria live is underneath the gum line. They live without oxygen. They're anaerobic. And once your gums begin to bleed and the epithelium is ulcerated, there's a direct communication into the bloodstream. This is the definition of the oral systemic connection, and I want a very, very clear illustration of that for my patients. I want to thank Bill Landers of Oratech for lending me this slide because this is an awesome slide. This is the instrument that Dr. Keyes introduced to dentistry. It was the video phase microscope. It is used chair-side to get instantaneous results to show patients. It's extremely inexpensive, and it visually gives patients an idea of what is going on in their mouth. So I'm going to give you a quick 30-second lessons on reading biofilms. On the left is health, on the right is disease, and in a risk assessment, it is absolutely this simple to see that an infected biofilm has a tremendous amount of motility. The more infection that there is, the more motility and the more angry that the bacteria are. If you have an extremely healthy mouth, things become very, very quiet and very docile. So this is kind of my overall overriding philosophy based on a long-term perspective. If we can test everyone biologically, every dental patient that comes in the office without any barrier to cost or comfort, and then only utilize the more sophisticated testing incrementally, and I'm going to explain what I mean by incrementally a little bit later. When indicated, we have optimized the opportunity for the majority of our patients to obtain the knowledge that enables them to make healthier choices. So you know in the first quotation when I talked about values and understanding and creating understanding, this is the process. And I'm very, very concerned about any barriers to clinical acceptance. I'm almost kind of obsessed with that when I'm working in a dental practice. So how was his approach accepted by mainstream dentistry? It was not, especially by the periodontal community. Over a 20-year period, the American Academy of Periodontics wrote 3 position papers against him, and he was constantly defending his technique. In 2005, the Board of Trustees of the American Academy of Periodontology were forced to rescind their papers. Everything on the internet was taken down concerning the Keyes technique. They couldn't take their position any longer because they were wrong. Periodontal disease is a bacterial infection. It's a transmissible bacterial infection, and it should be treated with aggressive anti-infective treatment modalities, be it antiseptic or antibiotic. So I think most physicians who are watching tonight probably remember Dr. Barry Marshall from Australia, who had a theory that that possibly ulcers were caused by bacteria back in the 1980s. And at first, he was a bit of an outlier and considered a quack. But 20 years later, in 2005, he receives the Nobel Prize in medicine. Dentistry has been pretty much more consistent as to how we treat our innovators and our outside-the-box thinkers, and it's kind of a shame. So here's my backstory, very quickly. In 2009, I moved to Lexington, Kentucky. This is what Lexington, Kentucky looks like this week. It's a breathtaking place to live. It's a very, very gorgeous place. I take a position at the University of Kentucky College of Dentistry, and it was kind of my retirement trajectory. I had taught at a university before, and I enjoyed it, and I was very effective with it. And I was there about 2 months, and I got a chance to speak to a practice management class. And I had taught practice management before, and I've written 2 books on practice management. But this 2008-2009 recession was brutal, very brutal on a lot of people and on a lot of dentists. So I knew that my first message was very, very critical, and I knew that the message that I was going to give was going to be very unpopular. And this was my message to the young dentist. If your dream in 2008 and 2009 was to become an exclusive cosmetic spa dentist, I want you to leave that dream behind today. And I went on to describe, this is a slide that really has defined me from that moment in 2009 to today. And I described that I felt as if the health-oriented dental practice was the largest emerging market opportunity in history, not in this week, this month, this year, in history. And this was based on my experience with, my private practice experience with KAIs. I knew that 2008 was an inflection point, and it will become a little bit more evident as we go on with this presentation. So fast forward 3 years, I'm now course director of practice management at the University of Kentucky, and I'm writing my second book called The Dental Entrepreneur, a Mini MBA. And I get to the chapter on dental hygiene. And dental hygiene is a business within a business. It's about a 1/3 component of a private practice. And I see an advertisement for a meeting of a group called the American Academy of Oral Systemic Health. And it's a fairly new organization. And so I go out to Las Vegas, and Dr. Bale and Dr. Doneen were the keynote speakers the first morning. And hearing Dr. Brad and Dr. Amy speak reminded me of the first time that I saw Dr. Kais. I knew it was one of those pivot points again, because it was just so compelling with what I was seeing and based on what I knew from my past. And so I'm flying back to Lexington, and I'm having this conversation with myself, and I said, boy, do you really want to do this? Do you really want to do what I think you're going to do? So there goes my retirement trajectory. Dr. Bale totally runs me off the rails. And I knew that I needed to get back into the game and to share my experiences, and it would probably require me to leave my teaching position. So the first thing that I did was I took the Bale Doneen preceptorship, became a patient of Dr. Bale's, and this is what I saw. I saw a very clear demarcation in both medicine and dentistry. And on my left-hand column, it's transaction-based disease repair. And I can tell you, I know so many young dentists who are in this type of practice today, and it's so discouraging. It's so discouraging. And on the right-hand column is relationship-based health and prevention. Okay. And in medicine, that would be your concierge-type practice, the Bale Doneen type practice. In dentistry, it's still undefined. That's what I'm working on a daily basis, is helping the dentist to how do we incorporate this, how do we make this a part of a practice the same way that some of the KAIs practitioners did. And I see just an unbelievable opportunity. So I came up with the term, the purposeful practice of dentistry. And here's what I mean by that. What I mean is that patients will accept transactional care if that is all that is available, but they will always desire, they will always choose, and willfully pay for relationship-based care if they can. And I'm going to come back to that statement again, and it's about understanding and values. Now, for the dentists in the audience, this is awesome. I just saw it, and I threw this slide in. It's a little bit out of order, but it's so awesome. Okay, so this is a really smart MBA who did an analysis of 70 dental practices, and he really drilled into the data. And he looked and he found one common component that was between the two practices, and that was the reappointment rates in hygiene, okay, as a critical component. So one practice is making $500,000, practice B is making $1 million. What is the number one difference between it? The number one difference was compliance with reappointment. The $500,000 practice had a compliance rate of 60%, meaning 6 out of 10 people kept their commitment to come in every 6 months. And in the $1 million practice, people came in at a rate of 90%. 9 out of 10 people came. Now, listen very carefully about my comment on values and understanding. Patient A, why do you come to the dentist every 6 months? I come to the dentist every 6 months because I like the way my teeth feel after the hygienist cleans them. Patient B, why do you go to the dentist every 6 months? Patient B says, well, actually, the truth is, I go every 3 months because I'm in a cardiovascular prevention program and I'm trying to reverse my heart disease, and I have seen my CIMT scores go down over time. I never miss my 3-month appointment with my dental hygienist. Now, there it is, right in front of your face. 2 practices identical, but with 2 different value systems, okay? These practices could be identical in every regard, and one of them has an income that's double that the other, okay? So what I'm saying is, when doctors tell me that prevention doesn't pay, they honestly don't know what they're talking about, because this is a study from September 27, 2016 that proves that the values of a 90% retention rate in reappointments and hygiene is going to double your income. I think that's an amazing study. I mean, I really look forward to telling people about this. So this is what I did with my sabbatical period as I left the university. This is a pretty big task. I've just finished. This is an operations manual, a complete guide to the development of an advanced preventive dental practice. And I've really tailored this to the Bale Doneen because it just makes so much sense to me. This thing just hit me so clearly. The right-hand book, I'm Free, No Cavities, No Gum Disease, was just published in the past month, and that's the consumer version of how to take care of your mouth. I have had young dentists ask me who looked at this say, you know, that's extremely bold. How can you tell people that they can have no cavities, no gum disease? And I look at them, I said, that's not bold at all. I've done it. I've done it over and over and over. It's a shame in our educational system today we're not graduating young doctors that have the kind of confidence that can come out and say, this is a very easily treatable disease. That's very, very sad. So I've given you the history lesson. I've shown you some of the most brilliant minds in history that came forward with this concept of changing the world with prevention, and they all failed for a whole variety of reasons. So the question is, why? What's different? Why now? Why did I leave the university? I left the university because I am convinced that something very, very special is about to happen. And it's 3 things that are coming together in a focal point. The number one thing is the Bale Doneen Method, okay? And I think most of the audience is relatively familiar with it, okay? The second part is demographics, and this is called the Silver Tsunami, 10,000 people a day turning 65. And these people that 20 years ago wanted the white teeth, the straight teeth, the beautiful teeth, and the cosmetic boom. That was the point that I made in 2008. That's over. These people have shifted into a different portion of their life. Their concerns are, number 1, brain health, number 2, event prevention, number 3, mobility. Okay, so if we're all entrepreneurs, we're all self-employed, we need to know what's going on in the world. And so many of those cosmetic dentists went out of business because they did not respond to the changing landscape of the world. Now, here's the economic component, and I think a lot of people here are familiar with the Concordia Study. This was an extensive study that looked at healthcare savings for patients who were under what's called periodontal maintenance, which might be a cleaning every 3 months. And across the board, patients from coronary artery disease to diabetes to pregnancies, the cost savings I mean, it was eye-popping. 28% decrease in admissions, savings here. Let's look at cerebral vascular, 21% reduction in admissions, diabetes, 39%. Now, I made a comment at the Scottsdale reunion that the standard of care, in my opinion, in dentistry is so low. I think this study is very, very understated. I will tell you for a fact that if this study was under the direct supervision of Dr. Kai's, meaning every one of those patients was under his supervision, these numbers would be significantly higher. That's why I think the oral systemic connection is even higher than what research shows. And so drug costs in diabetic patients, medical costs for pregnant women, you know, with our healthcare system today, with all the problems, they're looking for savings any way they can. And this whole oral systemic thing it's becoming very, very obvious to the insurance industry. So here's an article that I saw. Let's see, this is August of this year. Fidelity states that the average 65-year-old retired couple needs $250,000 to cover out-of-pocket health care between 65 and 85. I don't think people saw this article. Okay, this is mind-blowing. How many people have $250,000 sitting in their nightstand to take care of this? This needs to be a part of our conversation with our patients. Okay, I love talking about money and economy, and you know, because we have to make prevention real. You have to understand, I'm giving you a 100-year perspective on prevention, and I'm telling you why now is the opportunity to push this through. This thing is just absolutely, everything's pointing there. So here's my conversation. I'm going to make this really simple. I call it the anti-inflammatory triad. You need a clean diet, and I put diet in a separate category because it needs to be in a separate category. You need a clean mouth. You're going to have to find a dentist, and this is going to become apparent in about 5 minutes, that knows what that means. And you need a clean lifestyle, and that is under the direction of a physician, and preferably a Bale Doneen trained physician. Okay, so I can quantify this. What is that worth? To a retired couple, it's worth $250,000. Okay, so do you want to take a cruise, and do you want to enjoy your grandkids, or do you want to sit in a waiting room for the next 20 years? Okay, and here's your path. Here's your pathway right there. So the dentist has a new role. Okay, he's a partner in managing overall health, especially the inflammatory-based diseases. And the opportunity for the dentist is to address the connection, what I'm talking about, what is going on in the mouth and how it relates to their overall health. And there's a new language. I want every dental hygienist to use these 3 words every time. Okay, my least favorite word in the world is SRP. You know, I want to talk about biofilm, load, and disinfection. Every housewife in America knows that the cutting board in their kitchen needs to be disinfected so that they don't spread salmonella to the family and poison them. And why are we not using that language in the dental office to say you have an infection and we don't want it to spread? So there's an elephant in the room, and this is what I want to talk about specifically tonight when we're talking about the diagnostics and the clinical. So I'm attending a webinar a couple of months ago, and I met the hygienists in Scottsdale. We actually went out to dinner, 2 really, really sharp individuals. And the moderator in this webinar asked these questions. He said, I recommend all my clients to look at this oral systemic stuff and what's keeping the doctors from testing, and I see them try it and they quit, and if there's a negative experience, there's a tendency to quit. Okay, now that's a loaded question. They did not have the time to answer it, but I have to answer it because this is a really, really important question. Okay, so here's the answer. I call it the one and done oral systemic practice. Here's what happens. This whole concept of the oral systemic practice is very compelling. So maybe somebody attends this webinar or goes to a seminar, and they come back to the office and they say, man, I am all in. We are going to do this. He meets with his team, meets with a hygienist, and says, okay, from this day forward, we're going to start doing testing, and I want to implement this. The hygienist says, how much does it cost? And the doctor says, $150 to $200 out of pocket. So, you know, the hygienist is in charge of presenting this in most instances, and so after presenting maybe 10 or 15 patients, she finally gets somebody to agree to this. And Mrs. Smith, she says, Mrs. Smith, your gums are bleeding. we need to take a bacterial test because this is connected to this and you can get sick and blah, blah, blah. So they do the test, the patient comes back, positive above threshold for pathogens. Bingo. Okay, we got our first oral systemic practice. So Mrs. Smith, here's what we're going to do. We're going to do SRP. I'm going to see you 2 or 3 times, and then in 8 weeks, we're going to test you again. Okay, so they go through the process, test the patient at 8 weeks. Patient comes back positive above threshold. The doctor looks at the hygienist, kind of shrugs his shoulder. The hygienist looks at the doctor. The patient knows that they're out $300 out of pocket, and that's the one patient, one and done oral systemic practice. The dentist is not used to measurements like that. We constantly express opinions. And the example I gave in Scottsdale was like if a physician put somebody on an antihypertensive or on a statin, and you saw somebody on the recall visit, and you walked in the room and you said to the patient, you know, it looks like your blood pressure's down, and you took no measurement, the patient would think you're crazy. But the dentists are used to working in that environment. We express our opinions all day. Something looks better. We'll put a watch on that. We'll look at that. And so this whole concept of oral DNA in any bacterial testing where you're really put to the tests literally and measurement is going to be a problem. Okay? Now, let me tell you what happened to that patient. Okay? Here's what happened. 2 things happened. Secondarily, transmissibility. Okay, 99% of the dentists are going to miss this. And this is one of the things that Kai's really emphasized. If you're not achieving your therapeutic targets, meaning if your patient is not improving, but the compliance, the home care looks good, then the patient is getting reinfected from someone with substantial disease. Okay? Dentists and hygienists are not trained for this conversation. And so what Dr. Kai so eloquently described was this concept of therapeutic targets and modulation. Remember the word modulation? That means that we're constantly measuring and changing. Okay? So if I see that patient on the 2nd or 3rd appointment and I don't see progress, I need to talk about transmissibility. I need to see your partner. I need to see your husband. I need to see your wife. Okay? So this treatment is not a straight line, and the dentists are not used to that. And that's why I want to get involved in this to help the dentist with all this new great technology like oral DNA. I don't want them to see them screw this up. Okay? So that's the transmissibility. Now, there's one other person in the transmissibility conversation, and it's Fido. Okay? Smooching your pooch can lead to gum disease. Now, Bill Landers will help me with this conversation. It's a totally different conversation, but I thought you might find it of interest. The number one reason why that patient went from positive to positive over 8 weeks, I'll bet money on this, is technique. Okay? Incorrect technique. In every dental school in America and in the majority of dental practices, so for the people here that are non-dentists, this is an ultrasonic instrument to clean teeth, to clean debris off of teeth. 2 comments about going back to the Kai's times. When this instrument was first made, this instrument was very wide all the way down. And there was a dentist by the name of Larry Burnett back in the day, and he decided that if we sharpened and made this very thin, we could go underneath the gums. So the Kai's therapists, doctors, trainees, we were the first ones to have these ultra-thin tips to go under the gum. The second thing that you need to know is we never used water, ever. And so we rigged up bottles with a pressure bottle system, and we used diluted bleach, sodium hypochlorite, we used chloramine T, and we used BaleDoneen, providine iodine. It's a great antiseptic. It's messy and it stains, but it's a great oral antiseptic. Okay? So using water with this instrument is actually, in my opinion, dangerous for some medically compromised patients. I think you can set up a bacteremia. If you're a dental hygienist and you use this with water and you don't have full face protection, I want you to know that you could acquire periodontal disease from your patient from this infectious aerosol. Now, here's a research article that shows bacteremia following root scaling and planing at a rate of 70%. That shows that that procedure is dangerous. Bacteremias are dangerous in patients. This is an article from July of 2016 where the hygienist begins to talk about using chlorhexidine as an irrigant during ultrasonic scaling. And so I want you to know that this topic is like current. We were doing this 27 years ago, but this topic is now current. But here's the part that blew me out of the water. This last paragraph. This hygienist called 10 periodontists in her community and asked what they used as an irrigant. 9 out of 10 used water. That's mind-boggling, mind-boggling. So when I say the standard of care is low, I mean it. There's a misunderstanding of antimicrobials in dentistry. I'll prove it to you here. This is an article, a very recent article, about failures of root canals. 20% of root canals fail. And the number 2 suggestion by this doctor was, hey, why don't we use an irrigant that disinfects? I'm like, yeah, for sure, okay? So here's my recommendation. I have a 3-step process for diagnosis to improve your case acceptance. And then I'm going to go over a 3-step clinical. And these are very, very simple. Number 1 is visual, the phase microscope, seeing the bacteria. Number 2, and I want to thank Jim Hyland of Oral Vital for this video. This is really, really cool. This is called the papillary bleeding score. This is the second thing that I do this in sequence, okay? Now, I want to show a couple of things here. I'm going to pause this for just a second. For the physicians in the audience, if you were to have this patient open your mouth and you would look, and actually, as for most dentists, that patient looks fairly healthy. These gums are not red, they're not inflamed, the teeth do not have any debris. That patient looks healthy. But watch this. The papillary bleeding score was brought on by Dr. Walter Loesch in 1989. Dr. Loesch was a close colleague of Dr. Kai's. I think he was at Michigan. This is a soft pick. Every physician who's watching tonight can do this. If you take a soft pick, and I wouldn't do it in the front, I would do it on the side, and you put this in between the teeth and they bleed, you have your diagnosis of periodontal disease. Now watch this. This is a papillary bleeding score, and so this is actually scored as to how profuse this person bleeds. Now, this person you're going to see in about 30 seconds looks like they overdosed on Coumadin. I mean, this is dramatic. And this is shocking because look at these front teeth. I don't see disease. I don't see disease. That's why the traditional diagnostic methods, you know, to me they just don't work. We need a better system. This is a very lovely system. So I show them bacteria on the microscope, and then I do this. The patient is holding a mirror as I do the papillary bleeding score. Okay? And I mean, just look, it just barely touched this. Now, I don't have the audio on, but Jim is an expert on scripts, and he's talking about transmissibility and everything. I mean, you know, look at this. What a mess, okay? Now, this is the third component. So I show it to them. They see it. They feel it. Now they understand it. I have this conversation of bacteria under the gum, blood, circulation, okay? Those 3 steps. Now, if I take time to do those 3 steps, now I can have the oral DNA conversation. $150 is not a problem when we have understanding and values in place. Okay, that was my point of the very first slide of this presentation. We have to lay the groundwork to get the patients to value what we're talking about. We just can't say to them, hey, we're going to do an oral DNA, blah, 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 and then this is what happens. Okay, now, 3-step oral disinfection. Number 1, this is just a general irrigation. Strong antimicrobial cannula. This is heated. Doesn't require any anesthetic. They're for medically compromised patients and patients with infection. I would do this before I would do any dentistry on them. It just takes a minute or 2 to go around and do an entire mouth irrigation so that you can reduce the level of bacteremia. Okay, that most dental procedures can induce a bacteremia. Now, this is a low-powered diode laser. This can be, a dental hygienist can do this procedure. This is not what's called LANAP. Okay, that's a different lecture and that's a different deal. A hygienist can do this, okay, as a procedure to reduce populations of bacteria. Okay, very, very simple, very, very safe procedure. okay? The third thing is the ultrasonic instrument. This has a fiber optic light. This is heated. You can select, you can go from one antimicrobial to the next. You can put fluoride. It's a very, very slick operation. So here's my question. As opposed to using an instrument with water, and my procedure where you take 3 steps of debridement, irrigation, laser, and then this, what do you think the difference is in the outcome for that patient? Okay, that's why I'm saying we need standardization and we need a protocol for these patients, or we're going to be all over the map. Okay, now if your hygienist is having brushing and flossing conversations, you know, you're not in the game. You are not in the game. Okay, this is the conversation. Tongue scraping, which is surprisingly, culturally it's absent in America. In some cultures, tongue scraping is very important. I do it first. Okay, oral irrigation with or without antimicrobials. Soft picks over floss. Flossing is contraindicated in periodontal disease. There's research for that. Antimicrobial rinses, and now we have antibiotic rinse. Jim Highland. I've always been very conservative about systemic antibiotics, and now we're concerned about, you know, the gut and the health of the gut, and especially Flagyl and some of the antibiotics that we use in periodontal disease. They're brutal, okay, and I don't want to use them, okay. So now we have emerging modalities where we don't have to, okay. Now this is supportive home care, okay. Okay, I'm going to touch on radiology and the Bale Doneen method. This is a slide very, very similar to one of the ones that Dr. Bale showed in his first presentation that I saw. This tooth exists in almost every practice in America. It's asymptomatic, does not hurt to bite, there's no swelling, hot or cold doesn't bother it. It's a failed root canal, and the dentist here can say, whoa, that's a way failed. That's, you know, 6 millimeters short of reaching the apex. But what Dr. Bale was talking about, here is the mandibular neurovascular bundle, and here is this chronic infection with all of these pathogens, and in a 55-year-old male, this right here is a heart attack on a stick, okay? And when I saw that, I was like, whoa, okay, this is different, okay? Now I look at X-rays different. This is a real interesting book by a Dr. Nordquist, who is a University of Louisville grad, great things in Kentucky. Oral spiroketosis, the missing link in the heart disease labyrinth. He had a chapter in here about dental implants, and it really changed the way I look at that. So if you're a dentist and you're looking at that, what do you see? You see a failed dental implant. I do not. I see a failed root canal. And he has a whole chapter where he goes through the proximity of failed root canals to failed dental implants. And I'm going to tell you something. If you place dental implants, this is going to really drastically change your outlook on life. It'll scare the crap out of you, okay? You will be looking at adjacent teeth like never before, okay? This is a high risk situation. Okay, so I'm looking for a ConeBeam because I want to show a couple examples in this presentation, and this was the first one that came up on Google, and this is a dentist who's kind of advertising for his implant services. And I look at this and I was like, oh my gosh, I can't believe you put this online. Okay, so the dentist is saying, hey, man, I am cool. Look at this implant. This is perfect placement. I'm not near the neurovascular area. It's perfectly straight. Everything's cool. I'm looking at the film. What in the world jumps out at me right there? I mean, Dr. Bale did it to me. I mean, I'm just looking at this huge piece of snot on the end of that root. And I'm looking here. These are wisdom teeth that have tipped forward. I'm looking at angular bone loss, you know, 60, 70%. I got bone loss here. This guy is infected. His mouth is a mess, okay? So speaking of infection, let's look at some biofilm, okay? And this guy that I just showed you, this Panarex, this is probably what his biofilm looks like, okay? And you're placing implants, you're placing dental implants in this environment. It's just a recipe for disaster. It's amazing to me that dentistry hasn't put this all together. It's shocking to me that we don't look at biofilms before we do this. Okay, and this video is from Bill Landers gave me this, and it's amazing. Bacteria actually, as it becomes more organized and more sophisticated, you know, some of this stuff is kind of beautiful. It's neat stuff. And this is a chair side test. sample of the biofilm and put it under the phase microscope. Look at that. Man, how would you like to kiss that person? Nice. Okay, so back to cone beams. I'm watching my time here. I think I'm doing okay. I got about 5 more minutes to go here. Okay, this is a film I want to show you that if that patient came through diagnosis in the university, I'm going to tell you they'd get through there with flying colors. These teeth are asymptomatic. I'm going to come over there and I'm going to say, oh, we might put a watch, we might put a watch, we might put a watch, but that's okay. Now, this is why we have to have a cone beam level of image for the Bale Doneen method, okay? Going back to Weston Price, okay? Look at this. This is a lateral canal, nasty infection. Look at, I don't know what this deal is, but look at this infection, and then look at this post and root resorption, huge infection, mental foramen, mandibular canal, heart attack on a stick, okay? That's why you need cone beam as opposed to this. You are going to miss this all day in a conventional radiograph. Okay, a couple more minutes. This is a little miscellaneous. This is really cool. I had a physician friend send this to me. I don't know how many of you go to TEDMed, but TEDMed is awesome. This guy's name is Thomas Goetz. How can patients make better healthcare decisions? At the end of the day, all these things that we're talking about is we want our patients to make better decisions. And his whole premise was we need better healthcare records. So on the left is a conventional healthcare record, and on the right, now this is like 4 years ago, that this presentation, and he spent a bunch of money and he had this designed, and it says, your results, what do your results mean, what can you do, and so it's very intuitive, and it engages the patient, and it helps with compliance. Patients understand, hey, what did I just say? Values and understanding. Okay, if we're going to get patients on board with values and understanding, this is a tool. Okay, so guess what? Guess what I noticed? Cleveland Heart Lab, Boston Heart Lab. Guess who's doing it? They're doing it. Okay, they're making these very, very intuitive because it's engaging the patient in their own personal process. Okay, so when I saw that video, I just kind of dropped everything and I went to Photoshop and I said, you know what? There's nothing like this in dentistry. So we need to do this. And so I thought, okay, I'm going to make one up for the Bale Doneen dental protocol. And I took exactly his exact terminology. What do these results mean? What can you do? Caries risk assessment, desirable, borderline, high. Perio risk assessment, desirable, borderline, high. And so how we communicate with our patients, this is a tool that I think, it just fits into the whole process. So, as you can see, I'm very passionate about putting all of these pieces together. I'm in the process right now of taking my manual and putting it into an online course. And I really, really appreciate Brad and Amy and Julie in giving me the opportunity to speak in Scottsdale and to speak tonight, because I really, really am committed to making sure that this is going to be in a historic moment when this entire concept of prevention is punched through. Thank you so much. And I'm sure there are no questions.
Thank you so much, Tom. That was a fantastic presentation. I really appreciate you taking the time tonight, and all of you for also tuning in to listen to what Tom had to say. We are going to take questions right now, and I'm trying to see the question pane here. Just a sec. I know that some of you have that. Patrick, I'm looking for a little help here. Sorry about this. Thanks for hanging in there. If I can expand the question pane here. Okay. Oh my goodness, we have lots of questions. Okay. This is from Michelle Scanlon. Considering only 5% of dentists do this correctly, how do I find a good provider in my city, San Antonio? It's a very good question.
So is the question coming from a dentist or a physician?
I believe Michelle is a dental provider. Michelle, let me see if I can expand her. Sorry about this.
Hi, this is Amy Julie. I'm just going to unmute. Michelle is a medical provider.
Okay.
Oh, okay.
So
she's looking for a dental provider.
what a great question, because that is actually what Dr. Bale and Dr. Doneen and myself are in conversations with, is actually creating some type of a certification course and a database where, you know, so as a physician, you know that a dentist has a minimal level of training, and then when you refer a patient, that they understand exactly it is what you need as far as like the ConeBeam and the oral DNA testing. And so that is in conversation as we speak.
Oh, that's great. Then it looks like, so I'm going to read a couple of comments, and then I'm going to open up the speaker for a few people to ask you questions as well. Patty Metis says, great job, great presentation. Dr. Bale is on as well. And Brad, did you have something to say to Tom, or a question for Tom? I'm not quite sure if we've got him, so let's go down here. We have a question from Brant Brooks.
Hey, Brant.
Hey there.
Hello. Hello. We can take your question.
Hi. How's it going?
Hey, good to hear you, baby man.
Yeah. I just wanted to say that this is a great information. It's sad that the public or the private world is not paying more attention to this. When I worked in Kansas at the public health clinic, this was front and foremost. This is leading everything. This is how we're doing it on the public sector, and it is making a lot of changes in patients' overall health.
For sure. For sure.
Yeah.
It's awesome to hear from you. Brant was one of my students years back, and an awesome guy. Awesome.
One of my questions would be, what can we do as individual providers to bring this to our local culture, so our local dental society meetings and things, and basically not get laughed off the stage, so to speak?
Boy, is that just a very, you know, what a poignant question, okay? How do you do it? I mean, I think it's grassroots. I think you have to start in your practice, one patient at a time, and look for those opportunities. You know, what I'm working on right now is this whole relationship between dentists and physicians, because I think that's the relationship that really needs to be cemented first. And you know, once that is in place, then my idea is to go out together, okay? Because then I think you can answer the questions more completely.
Awesome. Well, thank you.
Yeah, and we need to get together. I know you're back in town.
Yes, definitely. I would love to do lunch or have dinner or something like that and talk more about this.
Perfect. Thank you.
That's great. Thank you. It looks like we have another question from Bruce Baird. Bruce, are you there?
I am.
Hi, Bruce.
Bruce, do you have a question for us?
You know, can you hear me, first of all?
Yes.
Yes.
You know, all I can say is just this last weekend is when I heard Dr. Bale speak, and then fortuitously we had already ordered Tom's. We'd already ordered your
Correct.
book or your manual with
Right.
myself and Dr. Boosky, and I'm
Right.
telling you, this is life changing. This is something that you know, you've done all the work from the dental perspective, and I think it's something that should be implemented across the board to dentistry, and we just have to find ways to get it into more dentists' hands. The physicians, I mean, from my perspective, I've already talked to 3 physicians in our town since I got back last weekend, and you know, they're skeptical but very interested because of the relationship that I have with them, and so I'm going to drag their butts to the preceptor, and then that's how we're going to affect people in the Dallas-Fort Worth area in the future. And I'm just I've been working on protocols and everything else based on your book and the stuff that you're doing, and I can't wait to visit with you when we're not talking here, but we can do that. So I'm super excited about this.
Well, and I'm super flattered, Bruce. I don't know if people know who you are, but you are one of the most prominent dentists in the country. Okay, and to hear that from you, I'm beyond flattered.
Well, I'm pumped. I'm really this is great.
Great.
That's great. Thank you so much.
I've had heart problems, so this is when Brad and I had dinner this weekend. I was just like, oh my gosh, I got to do this. So I'm already set up. I'm going to have Jeff, my partner. He's going to do the PLA surgery on me. I'm going to start rinsing with stuff. I mean, I'm pretty fired up, and so is everybody else around me. All my hygienists, everybody's pumped. So we just need to keep it going, and we will do that. So
absolutely. Yeah. No, I'm so flattered by the sentiment. This is awesome.
Thanks, Tom.
Awesome. Yeah. Thank you.
Thanks, Bruce. It looks like we have a question from Francis Breen. Let me see if I can unmute Francis. Not able to unmute. Let me see here. Oh, maybe, well, I'm sorry, Francis. I'm not able to take your question at this moment. It looks like there's maybe a question from Patty DeMathis. Patty, are you there? Patty, are you still with us? Not sure. Sometimes we have some microphone issues with everybody's computers in their homes. Let's just see here. Michelle, I'm going to try and unmute Michelle. And sorry, Michelle, I apologize about my slow response to if you're a medical provider or a dental provider. Did you have any other questions then for Tom, Michelle? I'm not sure. Let's just keep going here. Thanks, everyone, for hanging in there with me. It looks like we may have a question from Thomas von Sydow. Are you there, Thomas? Not quite sure what's happening. Are you there?
Yes. Can you hear me?
Yes. Oh, good. We finally connected here. So you have a question for Tom?
Yeah, I just want to know where we get the phased microscope.
Oratech, O-R-A, let's see, let me spell it, oratec.net. Bill Landers, and Bill Landers started out with Dr. Kais. He's been quietly selling microscope for 25 years.
Thank you.
Oratech.net.
That's great. Thank you. So we have some questions that have been typed out. Let's just see here. So Kim Packer wrote the question, how can we find physicians that will support the oral wellness platform? What I can tell you is that with the Bale Doneen Method, we put on 2 preceptorships that are open to medical providers and dental providers every year, and we have them on BaleDoneen.com. You can look and see, and you will also be educated and receive credits for continuing medical education. But we have hundreds of providers, medical providers, that have gone through our program that are willing, and we're looking for ways to help connect the medical and dental providers. And we have some teams already in place, which also come to our programs that we have, which are great connections and networking as well. So hopefully that might have answered a little bit of that question. Tom, did you have anything to add to that?
No, what I was going to refer to is the fact that you're compiling on an ongoing basis a database to create this match. It's going to be match.com for the dentist and the physician providers, because that's one of the the things that this needs to develop as this gains momentum, and not only providers matching up with each other, but the patients, okay, being able to start finding, you know, who the doctor is in my area, and you know, and that's going to happen. I mean, you're doing that right now.
Well, thank you. And we have Mike Rogers that typed a comment. Bruce, I met Dr. Mary Claire, I'm trying to read this, Mary Care, MD, at Bale Doneen preceptorship years ago. I believe she practices in Dallas. So we do have a provider map on our website as well. So and you can always give me a call and I'll be able to connect you. Lorene Gambicourt commented, fantastic webinar. We have a question from Jeff Busk. This is Jeff Busk. What is the best way you can have found to get this information out to the public to get them to come to the practice for an analysis?
Okay, what do I think the best way? I really like informational appearances. I've actually did one with the concierge physician, and we both presented, and you know, I think getting in front of anyone, any groups that are the proper demographic, yeah, you know, and I don't want to get into the whole marketing deal, but I've got some really cool ideas on how to push this out a little bit better in that fashion. But I like public speaking, obviously, because I like to talk.
Well, that's great. And I'm going to unmute Dr. Bale, who asked to have a moment to speak. Hi, Brad.
Yeah, Julie, great job, Tom. Yeah, I enjoyed the presentation. And Bruce, yeah, I'm glad you were on. And yeah, you're a giant out there, so you can help this whole effort for sure in a big way. But I just wanted to comment to the person who's on the dental side, wondering how they can get medical providers on board. And so far, one of the best ways we've seen that actually does work is the dental provider identifies some medical providers they know in their community, preferably internal medicine or family practice, and they talk briefly about our method and they offer them our book, Beat the Heart Attack Gene. And it seems like it takes about 6 to 10 books before the dentist finds a medical provider who actually looks at it. They get excited, and then they both come as a team from their community to our 2-day course. And at the 2-day course, after going through that, they're both on the same platform with the information. And what we've found is they go back to their communities and they put this into play. So you can find them, but you usually have to go through a few first. Now, if you're a giant like Bruce, it sounds like he can twist their arm, and you don't have to worry about twisting their arm to get them to the course, because once they go to the course and they hear the information, they'll never be the same. Our whole method is based on science. It's solid. It works. We have 2 peer-reviewed publications showing that the method halts, stabilizes, and regresses disease. So it's kind of like Maya Angelou stated several years ago, you do the best you can until you know better. Once you know better, you have to do better. You can't sleep at night if you don't. So it's just a matter of getting them there. It does take a little bit of effort, and I do believe our book can be a good calling card to find those medical providers to collaborate with in your community.
That's great. Thank you, Brad, for that. Definitely. So we're going to just take a few more comments and questions. We actually have someone, Lorraine Gambicourt, that asked the question if we had any physicians in Ontario, Canada, that have familiarized themselves with the Bale Doneen method. And Lorraine, I'd be happy to speak with you about that. We do have a few physicians that have gone through the program, and we have more that are interested coming, to incoming and getting more involved as well. So through our website, you can reach out to me directly as well. And then Frances Breen asked the question if we had the webinar on PowerPoint. We will have the webinar available on our YouTube channel and also linked through our website. And so I guess that we have not spoken yet with Tom, and so we'll have to discuss how he would like to move forward as far as sharing the PowerPoint. So we could be happy to get back to you about that as well.
That's fine.
Does that sound good? And then it looks like we'll take one last question from Kim Packer. And Kim, are you there? I'm not sure. It looks like we've taken quite a few questions. We are going to try to keep this as close to our time as we can. So thank you so much, Tom, for joining us and presenting. And it is eye-opening for medical providers as well as dental providers, and we're so excited to have you present for us and bring a perspective from the dental side of things as well. Yeah. And would encourage everyone to look at our website, BaleDoneen.com. We have our events, we have some online courses available, and we will have links to Tom's program that he put on for us tonight for you to share and watch again if you'd like to find out a little bit more. So anyway, thank you for joining us, and we will be in touch and let you know the next time that we have a guest webinar program available. So thank you, Tom.
Thank you very much. I appreciate it. Thank you.
All right. Thanks. Goodbye, everyone.